So LINNC bifurcation aneurysms account for approximately 25% of all aneurysms. They are challenging lesions to treat, and especially at the acute phase of the rupture. Often there are several therapeutic options, and I think that maybe it's because none are fully satisfactory. A few years ago in the CLARITY study, the authors studied the anatomic factors and their correlation to adverse events. And so you can see that a wide neck is associated with twice the risk of thrombus formation. And I think because of the time, the procedure takes more time if the neck is wide and you are more at risk of having a thrombus. And that's exactly the same for aneurysm size. For rupture risk, I'm sorry. So those aneurysms are challenging for both endovascular and for surgeons. And I think before we evaluate a new tool, we need to have proper data. And so this is what we can see when the data are fully adjudicated, and in fact they are disappointing for both endovascular and open surgery. So clearly there is a need for new tools. Of course, you can do with the new stents that we have beautiful reconstructions, but still it's technically challenging and it's not, I think, dedicated for ruptured aneurysm. Also, the safety is not what we are aiming for, basically, and to sum up, you have 3 times more risk if you use a stent compared to an intrasaccular device. So numerous devices came on the market, and today we are here and we are focusing on the artists. But I would like to share some general key points regarding my experience with intrasaccular devices. So what are the indications for artists? I think they are wide neck bifurcation aneurysms, but I would say they are any kind of bifurcation aneurysm because we are not only talking about feasibility, but I think the point is also the safety and the long-term result. So intrasaccular devices are safe, they are extremely safe, and I think this is their most important feature. Why do I think they are safe? Because you use a single device, it's easy to reposition, it's easy to retrieve, the parent artery is free from any material, and there is a reduced need for antiplatelet therapy. The first 3 features are very important for me because they give me the feeling to have a better control and to be in control of my treatment. For example, when you do a coiling and you can have a loop protrusion inside the parent artery, you are not in control. It's like when you have a misdeployment of a stent, and those situations are very challenging for all physicians, and especially for junior physicians. With intrasaccular, I feel that I have a better control. Also, the parent artery is free from any device. So you have almost 0 delayed event. Once the patient is leaving the hospital, there is no delayed event. And also there is a reduced need for antiplatelet therapy. And for sure, the post-op bleeding risk is almost 0. And I'm talking about major bleeding risk, but also all the small nuisance bleeding that can be very painful, especially for women. So the evidence for web is pretty solid, and I think it's coming from other devices. And I think what we can say today to our patient that if we use an intrasaccular device, the morbidity is less than 3 and mortality is less than 1. So for me, it's almost a philosophical question here because we all have our own sense of balance. And if you use intrasaccular, you are favoring safety. So for sure, you have to accept a certain trade-off. And this trade-off could be that you have maybe to deal with a certain amount of recurrences, but also I'm convinced that most of those recurrences should be treated with very much cautious because the associated risk, I think, is very small. So antiplatelet drugs are needed, but for a very short period of time, because maybe you will have to change your strategy, maybe you will need a stent as a rescue. But I think mostly to reduce the thromboembolic risk. When we see web series, there is a higher risk for ruptured aneurysms. So it might be due to a higher coagulopathy, but I think it's mostly because here, in this context, there is no premedication. But you will use antiplatelet for a very short period of time, and most of the time, you will stop any drug by the end of the treatment day. They are very effective, and I think that's the best indication to treat ruptured aneurysm, and specifically wide neck ruptured aneurysms. This is the first aneurysm I have treated with an intrasaccular devices. I think it was more than 7 years ago. This is very challenging aneurysm, and the patient is doing fine, and the follow-up, the patient has not been retreated, and the follow-up was very good. This is the case also that sometimes we are asked to treat before hematoma removal. And here you don't even have to use heparin. The treatment will be fast. You will use only one device and the patient can go directly to surgery and you can go back home safely. For sure, you can do beautiful things with remodeling. I've been trained by Jacques Moret and Laurent Spell. So for sure, you can do everything with coils, but it takes more time. It takes more expertise. The learning curve is way faster with an intrasaccular devices, and we see it in the department because the junior physicians are favoring intrasaccular devicing. Laurent has demonstrated that the web is very, very efficient to treat ruptured aneurysm. I'm sure it will come with the artist. Device shape. So here we've learned a lot. This is my son doing this demonstration. We've learned how to shape the device. If you have a flat surface, there is a weak resistance to compaction. If you build an arch or if you build an egg shape, you will have a strong resistance. And this we know from the web. And so we apply to the artist, and this is how you should use the device. You need this small protrusion of the proximal marker in the parent artery. It's completely okay. This is key for success. And still, if you are concerned, you can give some antiplatelet drugs, and it will still be less than having a stent inside the parent artery. For sizing, so for me, it's the same as when you use coil. By choosing the size and the deployment, you decide the final shape of the device. So for sure, simulation helps. We use it all the time, but you can you will also build your own sense of sizing with experience, and that's in fact easy. So we've talked about coils. For sure, you can do beautiful things with coils, but on the very long term, it's still difficult to have good results because I think you are not providing so much support for neck sealing. And that's the difference with intrasaccular, because it's very likely that you will have endothelial cells coming from the neck and closing the neck. And when you achieve a perfect neck sealing and closing, the aneurysm is gone and cured and forever. What was the impact of intrasaccular devices on our practice? So this is from 2015. You see an increased use of the web for ruptured aneurysm, and in parallel, a decreased use of coils. And this is mostly due to the usage of intrasaccular devices by junior physicians when they are trained, because they feel safe with the device and the learning curve is easy. Also, this is the global result from the team, and we are getting better. We have gained experience, and the experience that we have gained with other devices, we will apply to new intrasaccular devices. What was the large-scale impact of intrasaccular devices? This is very interesting. This was presented this year by Stephen Meckel during the ESMIN. So this is a very large real-life registry, over 70,000 of treatments. So this is for unruptured aneurysm. So I think it's like it makes sense to compare with stent-assisted coiling, and you can see that the morbidity and mortality are twice higher when you use a stent. Also, you can see that the procedure is in average 3 hours longer when you use stent-assisted coiling compared with intrasaccular devices. And also you see that it's overall 30% cheaper to use an intrasaccular device. Pretty much the same, the balloon-assisted coiling does not provide better results, and I think usually they address easier aneurysms. Quickly, when you look at ruptured aneurysm, for sure the morbidity is much higher when you use a stent, because I think of the complexity of the procedure and also antiplatelet management. You can see that intrasaccular devices, they have the lowest mortality in hospital, the lowest length of stay, and it impacts the global cost of the procedure. To conclude, some artist-specific reflection. Some people might argue that the available size are not sufficient today, so for sure more size will come. But I went back to the data from the department when we have used intrasaccular devices, and you can see that nowadays almost all the aneurysms that we treat are between 3 and 7 millimeters, and so they are totally treatable with the available artist size. Also, flow diverters are very different, and intrasaccular devices, I think you can judge the result after 12 months, because this is our experience. You can see that the short-term results before 12 months are almost the same that after 12 months. So thank you for giving me the opportunity to speak about intrasaccular devices, because I'm really convinced that this is the future, and I'm quite excited to hear Monica talk about the 12-month results. Thank you.
Thank you, Jildaz. So thanks to your talk, we have the frame for the discussions that we'll have. So yourself, Jildaz, you have provided a lot of work around the intrasaccular device, which was the web, initially speaking. So I would ask you, how is your approach with bifurcation aneurysm at this time? How would you choose for an intrasaccular device versus the other materials that are offered to us?
So at first, I was not convinced from the first day by the concept, but nowadays it's clear that for ruptured and unruptured aneurysms, my strategy is intrasaccular device first. And if I cannot use an intrasaccular, I would think of something else. But I would say that I barely use coils nowadays.
So we are training a lot of young physicians in the department. How would you perceive the impact of the intrasaccular device in their training? Are they willing to use them, or
I think
they are reluctant?
Been very well adopted by a young generation. Why? Because I think the learning curve is easier, because it's safe, and I think the young generation is very attached to safety. They are not here to try to do something spectacular, and also it's fast. And so when you come in the middle of the night or during the weekend, it's nice to come back home safely, and I think it speaks to the young generation, and to me too.
So short question for you, Cyril, you will be speaking about that, but I want to know how you decide to use the artist, especially regarding the size of the neck. So do you use the artist only with wide neck aneurysm, or do you use it?
Mainly on wide neck aneurysms, but for regular or irregular shaped aneurysms, if the simulation or my experience tells me, well, it will be okay for an artist, which is a very confirmable device, I can use an artist without problem, either for irregular or regular. For sure, at the beginning of the experience, I was more focused on a regular shape with large neck, but now we have very good results with other types of aneurysms that will show. So you can do many aneurysms, many cases with this device. Yes.
So as I told at the beginning of this discussion, I'm very glad to have this artist coming on the market, because it means that competition confirm the beauty of the treatment. So I have a question for you, Monica. You are a neurosurgeon as well. So in my opinion, of course, you have the competition in between the devices, but you have also the competition between the techniques. So how do you foresee the place of the artist regarding neurosurgical clipping?
I think neurosurgical clipping might stay in the field, but it's taken over from intravascular therapy anyway. But RTs and all the intrasaccular devices, as you said, coils are nice to have. But I think if you can use an intrasaccular device, why should you do a 3 hours clipping when you can do an aneurysm treatment in half an hour? I mean, this is the answer, even for surgeons.